Respected Chairperson, Dr. Nitin, senior faculty members, and my dear colleagues. At the outset, I would like to thank AIOS and APO for this opportunity to be here. Myopia, as we all know, is on a global rise, and it is expected that in the this year, around 52% of the world population is going to be myopic, of which nearly 10% are going to be in the high myopic range. The journey to correct myopia, especially the high myopia, was started long ago, long before LASIK was even thought about in 1953 by Strampelli. But his design was, as we all know, based in the anterior chamber, and it met with a lot of challenges, especially damage to endothelium and the pupil, and also the angle. This was basically because of the improper design, sizing, and of course the material. And through the ages, several attempts were made to keep this at various locations. The angle of the anterior chamber was one sort of the location. Iris fixation was also tried, but each met with different kind of problems. Ultimately, the breakthrough came when the phakic lens could successfully be placed within the posterior chamber. And this was safe because it was quite a safe distance from the endothelium. It did not disturb the iridocorneal angle, and also it was cosmetically very acceptable because it was not visible to the naked eye. And so today, I would like to present about the refractive implantable lens, which has been designed and researched and manufactured by the Appasamy Associates. I have no financial interest in this. It is a single-piece foldable phakic IOL. It is placed in the sulcus. It is made of hydrophilic biocompatible material. It comes in an overall length ranging from 11.5 to 14 millimeters in increments of 0.25 mm. And it has a fixed vault of 400 microns to 700 microns. It has got a central hole for aqueous filtration with two peripheral holes, and also got marker holes in its foot plates for identifying the unfolding. Just to compare it with the Collamer lens that has been predominantly been used earlier, the thickness is about 127 to 390 microns, whereas the Collamer is about 100 to 200. The vault is about 1.62 to 1.91. The Collamer lens doesn't have a fixed vault. The filtration holes are comparable. The overall length of the RIL is 11.5 to 14 with 0.25 increments. The Collamer has got 4 standard sizes. The toric rotation required for the RIL is less than 10 degrees, whereas the Collamer requires up to may need up to 22 degrees of rotation. So the preoperative data that is required, especially as for all phakic lenses, essentially the same, not much of different. The online calculator is not yet been launched, but it's going to be very soon launched. Presently, we send the preoperative data to the company and they calculate it, but very soon this is going to be launched. This is just the prototype of what is going to be launched. What I want to highlight about the RIL is especially the ease of handling, because as we saw in the comparison, this is a much thicker lens. So one of the problems of the Collamer lens is the folding of the lens, which sometimes leads to crumpling of the lens within the cartridge. Here, if you are a regular phacosurgeon, you can just use your regular hydrophilic cartridge. You don't need a special cartridge, or you don't need any special instruments to handle this lens. The only main point is that you have to look at the leading position, the holes on the leading haptic on the right and the trailing on the left. You load it within your cartridge, and that is it. You're done and you're ready for implantation. So the first key point is the ease of converting from a phacosurgeon to a phakic surgeon is very simple with this, especially folding it and loading it is very simple. Coming to the implantation, I prefer to do with 2 side ports, one at 6 o'clock and one at 12 o'clock. I use intracameral lignocaine. The viscoelastic that I use is the low molecular weight, though currently there are people who prefer to use the high molecular weight viscoelastic, which easy to remove. It comes out as a single mass. But if you're not a phacosurgeon who's routinely used to high molecular viscoelastic, maybe you should start with low molecular weight viscoelastic. When you begin, the preferred incision length would be around 2.8 to 3 millimeters, but you can take it down to even 2.2. It's possible to implant to 2.2. And again, deepening at the site of implantation. Now, one of the key points I want to highlight about RIL in comparison with collamer lens is you can even boldly shoot it from the tunnel. You can have an incision-based delivery compared to the collamer lens where you have to take your injector right up to the middle of the anterior chamber. Otherwise, there is always a risk that the lens may flip or it may rotate as you shoot it from the tunnel because of the extreme flexibility of the material, which is very thin compared to the RIL. Only you need to keep watch that the leading position hole is on the right and the trailing position hole is on the left, and that is it. And the other key point I want to show and highlight here is that compared to the collamer lens, you don't have to even deliver it on top of the iris. You could even take it into the sulcus because in a collamer lens, because of the extreme thinness of its footplate, there is a risk that if you inject it to the sulcus, the footplate gets folded and it remains folded in the sulcus. And that can lead on to the lens not being stable in the sulcus and sometimes coming into the anterior chamber, auto-subluxation into the anterior chamber. Whereas in the RIL, because of thicker haptic, there is no risk that the haptic gets folded or of auto-subluxation into the anterior chamber. The next key point I want to show in this implantation, in a collamer lens, you are strictly warned not to cross the optic because there is always a risk that the optic can get damaged if you take your instruments across the optic. Whereas this being a regular hydrophilic lens, you can use, and I also showing a Simcoe being used because I wanted to show that this is in the reach of a regular normal surgeon who may not even have a phaco machine. He can as well do this. And you can boldly wash over the optic, touch the optic. You can, nothing is not going to damage the optic in any way. So the ease of implantation is very good in this lens. Coming to a brief about my experience with RIL, my patients have ranged from the age of 18 to 45, spherical equivalent ranging from -6 to 23, cylindrical power up to 4.25. Looking at the post-operative results, at 6 months, most of my patients have been within 0.5 diopters of emmetropia, both in sphere and cylinder, and they have maintained the spherical equivalent at a follow-up of 6 months or more. Preoperatively, about 70% of my patients had above 1.5 diopters of astigmatism. At 6 months follow-up, more than 95% of the patients, they maintained the correction within 0.5 diopters of astigmatism. And there were no IOP spikes which were noted either in the early or in the long-term follow-up of these patients. So in general, phakic IOLs present a distinctive advantage over corneal refractive surgeries. There is tissue preservation. It can be, and the second point being that it can be used to treat extremely high levels of myopia and astigmatism. And then, of course, the quality of life. It provides better quality of vision. There are no issues like dry eye. There is no induced higher order aberrations. It has got a long history, as I said, starting from 1953. And there are no added complexities in future IOL power calculations, especially as you see in post-corneal refractive procedures. And of course, it is easily reversible. You can always remove it anytime you like. So in my experience with the Apasami's refractive implantable lenses, they had very stable refraction post-operatively up to the follow-up of even 1 year. And they achieved preoperative best corrected visual acuity up to 95%. None of them developed cataracts or any other iris-related problems. None of them had any early or late IOP spikes, and none of the patients required explantation. So, in conclusion, I would very confidently recommend Appasami's RILs as a choice of your phakic IOLs. Thank you very much.
Thank you, Dr. Varkey.